finished my PhD at University of Minnesota, my main clinical specialty was rehabilitation of recreational runners. So it's always been a special interest of mine. Thankfully, due to things like apps, it's way easier than it used to be. Now, there's a great deal of variability between individuals in gait kinematics, so it's really important not to get too excited about every variation that you see unless that variation goes toward explaining the problem that the patient has come in to see you for. For example, if you see a patient with unilateral Trendelenburg and superior medial hip pain, then probably indeed there's an important link between what you see and the patient's problem. However, if you see unilateral Trendelenburg and the patient's problem is Achilles tendon pain, then the conceptual link is way smaller, and you'll just be probably chasing a red herring if you worry a lot about that Trendelenburg sign. So what we're looking for when we do a video analysis of running is signs of poor neuromuscular stability of the trunk, pelvis, or leg. And then really important, because the most important tool that you bring to evaluation is really not your hands, but your clinical reasoning skills. Do the things that you observe with your running analysis confirm your hypothesis from your clinical exam? So the first thing that you might look at in the sagittal plane analysis is swing leg displacement. Remember, swing leg displacement is a sign of hamstrings control, because the hamstrings link the leg back to the trunk, and that makes the biggest source of propulsive momentum. So if you see too much displacement of the involved leg, then what that is probably indicating is poor hamstring performance, because it's not controlling the swing of the leg and not linking that kinetic energy back to the trunk for propulsion. So we want to look at the shank angle at the point of foot touchdown. This woman in the picture is actually doing a problem which we call overstriding. Overstriding means that the runner's foot is either going forward as fast as the runner's trunk, or even advancing forward relative to the trunk by the time it hits the ground. And this is a problem because what you have with overstriding is an increased braking force, such as you see with the arrow here, applied to the foot of the runner that is making initial contact. And that not only slows the runner down more than we want, which is certainly not what the runner wants, but also because of the increased external plantar flexion moment, which may lead to overload of the anterior tibial group, also leads to an increased external knee flexion moment, such as we see here. The external knee flexion moment has to be controlled by the generator of the internal knee extension moment, the quadriceps, and so this kind of gait pattern is also frequently associated with patellofemoral problems. In some cases, it's important to keep an eye on the angular displacement of the knee. For example, I've worked with patients who have had ACL reconstruction. Sometimes they're unable to generate sufficient stiffness, and you see the knee angle increasing and increasing with subsequent time, or they're unable to neuromuscularly absorb the energy of contact, and you see a real stiff angle, so a really small angle that they have on the involved knee. As we were seeing before, the direction of the shank at the point of foot strike is really important, because you want the shank to be going backwards relative to the trunk and the thigh in order to be decreasing the ground reaction force, decreasing the braking force. If you got a high braking force, we talked already about some of the consequences of that. Now, you also want, with some patients, to be watching out for the angular displacement of the ankle. And remember, the important thing is symmetry. I've worked with patients with Achilles tendinosis, which is a really common problem for runners over 40. And what you see with them, because what they've lost is stiffness of the Achilles tendon, so you see with patients like this that the ankle angle at terminal stance is way higher on the involved side than the uninvolved side, because they're not able to generate sufficient ankle stiffness to control the external dorsiflexion moment. You want to be able to look out for the hip extension relative to the trunk if your patient's problem is lumbosacral or sacroiliac. You want to make sure that they've got sufficient freedom of the hip flexors and not taking all that force in the form of anterior shear or anterior tilt of the pelvis. In the frontal plane, from the bottom up, you're looking first of all at the trunk, and the easiest way to do that is the head relative to the sacrum. You want the head to be right over the sacrum. If not, what you might look at, if you see an ipsilateral trunk shift, you look at the ipsilateral hip control, or perhaps a contralateral trunk control. Either one of those would explain the ipsilateral trunk shift. This girl actually looks pretty good for a 9-year-old. Children that young tend to be flexible instead of strong. So considering how young she is, she's actually doing pretty good. You're watching out for the Trendelenburg sign of the pelvis, the pelvic rocking, and you need a little bit of pelvic rocking to help absorb the external hip adduction moment, but it should be within 5 or 7 degrees and should be symmetrical. And then finally, you want the thighs and shins to be in the same plane. They may not be in the sagittal plane. Most people have a little bit of turn out coming from the thigh, but they should be in the same plane. I'm going to show you some examples of patients who had particular problems so that you can see what they're like. Now, here's a patient who had a very severe contralateral hip drop on the right side, as you see. So on the left side, her hip drop is about 5 degrees, which is about what it should be, but on the left side, her hip drop is 12 degrees, which is much excessive. Now, also, I think what's interesting, and I want to bring to your attention, is look at the leg on the involved side, and you see this adduction of the thigh and dynamic valgus of the knee that you don't see on the right side. That makes sense because remember that the gluteus maximus is really a 3-dimensional muscle, and so what we may see here is not only a failure to control in the frontal plane, but a failure to control in the transverse plane. I think that you're likely to see both of these things simultaneously. Here's another person who has got just a really extreme version of a dynamic valgus. And what you're going to see, or the point in the gait where you're going to see this, remember, is where the body is working the hardest to absorb the force of contact. So when you're taking these videos, watch and see how low their center of mass goes. You can see that from the head or the pelvis. And when the center of mass is at its lowest, for these sorts of questions of the ability to absorb those external torics, that's when you measure with your angles. Finally, pronation and supination. So there's a lot of variation in pronation and supination. The important thing really is the sequence. Does the patient get from pronation, which he should have as part of the loading response and part of weight acceptance in order to help absorb the energy of foot strike, but do they get back into supination or at least neutral by the time they're in terminal stance? Secondly, If they don't, does that failure of getting back into supination really explain the problem that they have? If their problem is plantar fasciitis, absolutely. If their problem is um, Achilles tendinosis, perhaps not. So again, think of the conceptual link between what you see, because any person is going to have a lot of abnormalities, and does that kinematic abnormality that you're observing really explain the problem that the patient has? And there is an expression that the hand is quicker than the eye. It turns out that it's really not hard to be quicker than the eye. The visual sampling rate is fairly slow, and that's why it's so important to use video and to use apps to observe not only things like running, but to observe exercises and to see if the patients are able to maintain alignment during corrective exercise. So this young woman in the picture, for example, is intentionally demonstrating a really horrible dynamic knee valgus, but she's doing it bilaterally. Doing it bilaterally is easier than doing it unilaterally and running. So if she were my patient, I would make sure that she was able to do the box landing, then the box jump, without that dynamic knee valgus until I would allow her to progress to running. We've said it before, but one more time, I'm going to repeat it. If you observe carefully a human being, you're going to see all sorts of abnormalities in their movement pattern. So please be careful not to chase red herrings. The important thing is to develop a clinical hypothesis based upon the description of the patient's symptoms, and then through doing your objective observation, and the video analysis is one of those tools of objective observation, you're testing that hypothesis. That's what good physical therapy is.